Is it
Right,
visible?
Ritu ma'am?
Yes, sir.
Yes.
Is it visible?
Yes, now it is visible in the slideshow with the peacock feathers, which is symbolizing the eye shape.
Yes,
Okay. And
exactly.
it is also the national bird of India, where this all the AOMPT's techniques are along the Make in India, okay, of the revolutionary prime minister whom we have in India now, right? Yes,
Yes, sir.
Ritu ma'am. Yes,
Yes,
best
sir.
wishes. Go ahead with your PPT.
Yes, sir. Thank you so much, sir. Yes, sir. Good evening, everyone. Today, again, we are back with a new topic in the guidance of Dr. Senthil, sir. As, although we know that this optometric part is, we never relate with the physiotherapy. But as sir was explaining, if we are going to treat the vestibular patient or we are going to treat the vertigo patient and the cervicogenic headache, migraine, if the headache related to their the visual problem. So there is a, I think it's a mandatory to learn more about the eyes. What is the eye structure? What are the nerves which are going to supply? What is the vascular system? What is the arterial and the venous drainage? So it is all very important for learning about the visual, because as I have taken this symbol of that feather of peacock feather, because today I was just doing some puja in my temple. That time I was just see this feather. So that time, because I was preparing the PPT of eye, so my focus was on that only on the eye part, the eyeball. So I have thoroughly see this. This is the same, the symbol of eye, where the all the layers of outer layer, middle layer, and the inner layer, and the same the center, how the cornea, how the lens is situated. The same was in this feather. So I was so inspired by this image. It is matching with our presentation. And same thing that if we talk about our Hindu mythology, where we know that Arjuna was, he was focusing on the eye of that particular fish when he was giving his arrow on that direction. So that time, so same the our vision of AMPT is also that the patient centered approach. We have to just focus on the patient, not here and there. There's a no need to check all other things, only the symptoms of your patient. That is very important. And how you can see your patient symptom, that is also the gift which is given by the God, our visual, our eyes. Sometimes without telling any word, we can see, we can understand the pain of patient with from their eyes. So when their eyes are they are telling words about their pain. So it is very important as a physiotherapist to understand the visual disorder and to understand how we can read the eye of some other person who are in a pain. So it is very important. So for that words, I am going to start my presentation about the anatomy of the eye, so that when sir will explain as a practical demonstration of on that eye, we can easily understand that at what structure sir is going to explain, and where we have to give the articular technique, or where we are going to use the myofascial technique, and where we are talking about the cranial nerve, so how we can mobilize that particular nerve also. So it is very important topic. So every physiotherapist, they should learn about these things, because in our daily practice, we see the patient with the cervical problem. So how we can forget the visual problem, because all time whenever we treat the cervicogenic headache or the sensory integration, the eyes plays a very major role. So for these words, I am going to start my presentation. So for the topic, because we have taken this topic, so it is very important, because today's session, through the last 2 years online classes, the students or the people who are working from home, they are sitting with the laptop 24 hours, they are using, the strain is coming. For that, this is very important. When they come to physiotherapists, they explain their pain, musculoskeleton. Sometimes they explain their pain, visceral problem also, but they never say that, yes, my eyes are in a fatigue. So now it's our turn to add in our evaluation, in our assessment, that what is their visual problem. Are there the changing of, like sir was saying, that in a supine position, sometimes people feel more pain in their eyes, or there are more tears comes when they are in a sideline position. So this is the important point, which from after today's session we will add in our evaluation, asking about the question of where their visual deficit is coming. Either the visual field is deficient, or is there is a intraocular pressure. Because of that pressure, they are not able to focus on the screen, because I am also struggling with the vision problem. So I can easily feel and understand the pain of other person who is struggling with this problem. So it is very important today's session where the strain, painful vision, dryness, redness, itching, fatigue, blurred vision, that the people are, not only the young people, the small kids are also suffering with this problem. So it is very important to understand the about this topic. For this, in our AMPT last year, we have complete our course, which was the cranial neuromanual therapy, where we have given the nerve mobilization to the particular cranial nerve, all the cranial nerve. But according to today's topic, the nerves which are participating in the vision problem, like the oculomotor, it is completely a motor nerve, the trochlear, ophthalmic nerve, and the abducens, optic, and the trigeminal nerve, which is the sensory nerve, because their ophthalmic branch also gives the movement to the eyeball, the dysfunction in the eyeball movement. So that is also very important for the understanding. Or if I will talk about the osteocranial manual therapy, so how we can release that the orbital fissures, the superior and the inferior orbital fissure, or how we can check the occiput, or how we can combine our treatment with the oculo-occiput technique, where we keeping our hand according to the patient symptoms. So that is also, these two courses are the main focus of today's topic. Because of that, we can easily understand that what is the visual disorder. So we are going to start the anatomy, because although we as a science student, we all know from our 10th to 12th class standard, we were going to understand about the anatomy of eyes, what is the structure of eyes. We all know about that, how it is divided into the three parts, three layer, how the lens works, how the retina is the main focus where the image is coming, or how the optic nerve, cylindrical optic nerve, plays a very major role for the nerve supply. So it is all that how we can understand there is an anterior chamber, posterior chamber, where the intraocular pressure for the aqueous zone, or there is the vitreous chambers where the jelly-like gel is there. So according to that, how they give the stability to giving the spherical shape to the eye, the vitreous chamber. So these are the thing, and there are some, you can see it, there is a one ligament also, that is called the suspensory ligament, which gives the protection to the lens, so that the lens will not be displaced from their place. So this is also very important when we talk about the articular. So there is a ligament also, and as well as sir was saying that how the orbit, how the sutures plays a very major role as a articular dysfunction. So there are the myofascial, how all the myofascial, the muscles which hold the eyeball, how they work because of their eyeball movement, their eyelids movement, or there is the movement of particular in one direction, contralateral or ipsilateral, there the extraocular muscle plays a very major role. So we are going to see one by one that how we can easily differentiate between the chambers of particular eye, and we can easily enter in the eye according to the first layer to the third layer. So the eye, we know that this is the between, when we see the skull, we can easily understand that how this is the skull, there is a orbit, we can easily see that the placement of the eye. So it is very easy to understand that if it is situated in between the skull, so the articular part of sutures plays a very major role, where the frontal bone, the parietal bone, that all will affect the working of the eye. So it is the orbit which gives the bony walls to the protection of that particular eye. And there is an eyeball where the nerves, blood vessels, and the lacrimal glands plays a very major role, so that the person who is having a problem with their, sometime with the tears problem, their dryness, so according to that, how the lacrimal gland is not working, so that they have a problem with the dry eyes. And if there is a blood vessels, they are not getting complete the sufficient supply of the blood, so the vascular part that not supply is coming, so the intraocular pressure will also be less. So the patient is having there is a problem like glaucoma is coming because of that intraocular pressure. So there are so many dysfunction which related to the eye structure also. So it is important to learn properly and treat properly. The structure of the eyeball, the wall of the eyeball, and the light transmitting media or refractive media, the two main part functions, the structure the eyeball gives to the eye. because the wall, it gives the protection to the eye, and the light transmitting media, that is also because of that we are able to see. Wall of the eyeball, there are 3 layers in the eyeball, which we can say that outer layer, that is a fibrous coat, which give the holding that balance to that particular eye, and the sclera and cornea is the part of that outer layer. If we talk about the middle layer, that is a completely a vascular coating, where is the choroid and the ciliary body and the iris, 3 part it makes with the vascular coating. And as we go enter the eye, the inner layer, this is the nervous coat where the retina is placed. So it is also very important part of, you can see in this also, that pupil, sclera, iris, and this cornea, how it is giving the proper outer, middle, and the lower layer. And in this, you can see that this lens is situated, because nowadays the cataract is very famous surgery of all the people who are going for a cataract. They particular opt for the better lenses, because there the need of the change of lens is very important. So they opt the best quality of lens because of better quality of their life. Because when the patient is having a diabetes, so their lens, their visual problem is very high because of the diabetes. So that time they need to replace because of cataract, they replace their lens, or after that they can easily see. So there are so many dysfunction related. So if according to the eye dysfunction, but here our role is to mobilize the cranial nerves, which are going to supply the eye, and the muscles, the extraocular muscle, which are going to stabilize that particular eye structure. So we have seen that this wall of eyeball is divided into 3 parts: outer, middle, and the inner layer. First is the fibrous, second is the visceral and vascular, and the third is the neural part, where the nerves part are more higher than. And it is divided according to that: outer in the cornea, sclera, middle in the choroid and ciliary body and iris, and retina is the layer of retina. And it is because of the presence of the nerve fiber. It is there is a blood supply is very rich there. And this outer layer, it gives the shape of the eyeball and contains sclera and cornea. This you can easily see in this picture also. And as we all know about the eye, we know that this outer layer, about that how the sclera, the white part of the eye, and the cornea plays a very major role for our eye vision. This is middle layer. This is also again divided into choroid, ciliary body, and iris. And it that all 3 structure main the via. This is the via, that choroid, and this ciliary body is the further progressive part of the choroid. And after that iris, and in front of the iris there is a small pupil, and behind that there is a lens, and there is a aqueous zone, and there is a vitreous zone. So these layer contain blood vessels. So it means if there is a high blood pressure or the low blood pressure, so that time the patient feel pain in their eyes because of that the blood pressure, because there are the blood vessels which are not getting proper supply there. And the pupil is the small opening in front of that particular lens. This is the inner layer. In this retina is the light sensitive membrane. You can see in this picture, this is the optic nerve, and how this is the retina and choroid. This is the lens and the pupil. So this is a very sensitive membrane, retina. And the sclera and cornea, sclera or the white of the eye forms because we know that the white part of our eye, this is the sclera. You can see in this picture also. The anterior 1/6 part of the sclera is transparent and also known as the cornea. This is the cornea part. The cornea is described as the window of the eye, and the light rays pass through the cornea to reach the retina. Because if retina is in the inner chamber and the cornea is in a first chamber, so how the rays which entered through the it's like a curtain of our window from where the rays enters into the room. So like the window, in between there is a window, the middle part of that eye. So from the curtain, the rays enter into the room through the cornea and goes towards the retina. So it is the same structure. We can understand about the eye, that which part is playing a role of window, which part is playing a role of curtain, and how the rays are entering in that innermost part, like in our room. What is the function of sclera? It provides protection to the delicate structure. As we all know that if some foreign particle entered in our eyes, first we just the itching start in that sclera part, where we just do the itching on that part, and after that there is a sometimes there is a fluid, that water it will start coming from, like in the lacrimal glands become active, so that water comes out. So this is like a very it gives the protection to any foreign particle which suddenly if it enters, and sometimes we hit our finger itself, or somebody hit on our eye. So how that sclera, that is, it protect our eye, because our eye is a very delicate structure, and it is also resist intraocular pressure also, and it maintains the shape the eyeball, because if there is a eyeball shape is displaced from one place to another place, after that there is a cases of paralysis, either the lateral rectus or the medial rectus plays a very major role there, the oculomotor or the abducens nerve, the because of that the paralysis come, that this eyeball shift is coming because of their paralytic position. But normally that the sclera give the shape to the eyeball, and the smooth external surface allow easy one movement. When the eyeball move, it gives the movement. If there is a some infection, or there is something inside our eye, so that time that sclera become inflamed and it becomes red also, that we normally we can see in if there is some problem with the eye, we can see how the sclera becomes red in compared to whiteness. So this is the choroid. It is also a thin pigmented membrane, dark brown in color, which is situated in between the externally or internally. Externally, what was there is the sclera. Internally, there was a retina. In between, there is a choroid that you can also see in this. This is the sclera. This is the outer side structure, which is giving the protection to the eye. After that, this is the choroid. This is in between this purple line, and this is the retina. This is the innermost structure. So how it is giving the protection? Choroid is getting the protection from outer side sclera, and inside there is a retina. So it is also a very important part of our eye according to the structure. Ciliary bodies, it is continuation of, I have already explained that how it is the choroid body, it comes in the continuation with the ciliary body. These ciliary bodies also protect the eye. They are consisting with the smooth muscle fiber, that is it, they are known as the ciliary muscles, and it also gives a protection to the eye. And it contains suspensory ligament, which we have seen that in previous picture we have seen this. These are the ligaments, the suspensory ligaments, which hold with the ciliary body, it is holding the lens also. And these ciliary muscles help in accommodation by adjusting the thickness of the lens also. So this is also a very important part of our eye. Iris, it is a pigmented membrane surround the pupil, that you can see that this is, and it arises from the margin of the ciliary body and forms a dark centered opening for the pupil. This you can see in this picture. This is the pupil, and this is that how it is formed in between that. This is the dark center, and its color, sometimes it is the color of this your pupil and the color of iris is different in other people's also. The space between cornea in front and the lens behind is the anterior segment. There is an anterior segment in this, and this is the posterior segment. In between this, there is a iris. So it is again divided into two parts by the iris. The space between the iris and cornea is and one is anterior chamber and one is the posterior chamber, and that is the both are filled with the clear fluid, that is the aqueous humor. Retina is the innermost layer of the eyeball. This is also a very important part of our eye. It is a very thin, delicate layer, continues posteriorly with the optic nerve, where the role of optic nerve, because it is completely attached with the optic nerve, the outer surface of the retina formed by pigment cells, and it is attached to the choroid, because the same formation is because it is in the inner side. So outer side there is a choroid, in between there was a choroid, so it is attached to the choroid also, and the inner surface in the contact with the hyaloid membrane of the vitreous. Now anteriorly there is a aqueous fluid, and there is in the posteriorly there is a hyaloid membrane with the vitreous fluid also. So the small area of retina where the optic nerve leaves the eye is there is a small disc-like structure, that is the optic disc or a blind spot. We know that it has no light sensitive cell, that is known as the rods or cones. So the retina has, again, it is divided into three parts: optic, ciliary, iridial. The optic part contains nervous tissues and it is sensitive to the light. It extends from the optic disc to the ciliary body. The thin, non-nervous, non-sensitive layer covers the ciliary body, and iris is called the ciliary and iridial part of the retina. Lateral to the optic disc, a depression called macula. It is also a very important part, and due to its yellow color, it is called as the macula lutea. The center of macula is again depressed to form the fovea centralis. It contains cones only, and it in the side of maximum acuity of vision. The rods and cones are the receptors. In this, the rods and cones, they are the receptors of the light and the side. These cells contain photosensitive pigments. Rods, that is the rhodospin; cones, that is the ledospin, involved in the conversion of the light rays into the nerve impulses. It means the part of that area where the disc, the optic disc, there is a depression called the macula, and because of there is the pigmentation, the color, the photosynthesis pigment are related to this. It means that is the light sensitive part of the eyes, and it is very sensitive because of that. Sir was saying that in the migraine, some people are not, they are photophobia, they are, though they don't like the highlight. So according to that time, the rods and cones receptors of light and sight, these cells becomes weak. So because of that, they are not, they don't want to face that highlight because of their photosynthesis of these pigments. So this is the blood supply, where the arterial blood is supplied by the branches of ophthalmic artery, ciliary arteries, and central retinal artery. Venous drainage, a number of veins, including the central retina vein. So this is all a very important part of the eye. After that, there all the structure, that what is going to supply the blood there and what is going to supply the venous system. And the second was that the light transmitting media, refractive media, which we have already discussed about that vitreous chamber and the vitreous humor and the aqueous humor and the lens. This is, you can see, this is the posterior part and this is the anterior part. And in this, there is an anterior chamber, posterior chamber, and there is a lens. So you can easily understand that how it is important that if the patient is having a high blood pressure, so how this pressure, if pressure is very high, so how it will affect your eye pressure. According to that, when the patient goes for the testing, first doctor, if there is a diabetic patient or they have a glaucoma, first they check their intraocular pressure. After that, they dilute their lens and then they start their testing. So this is the main basic part of that eye testing, when they start their testing with the intraocular pressure of that aqueous humor, where they check the pressure. So this is aqueous humor. You can see in front of the lens is a clear fluid. It is a very clear fluid filled with the space between cornea and the lens. It is secreted by the capillaries of the ciliary process, and from here the fluid reaches to the anterior chamber, which finally reaches to the canal of Schlemm. And with the interference with this, if there is a interference of drainage of this aqueous fluid, so it result in an increase of intraocular pressure like a glaucoma. So because of that, the patient is not able to do their vision is not proper, and every time they will feel that there is some fluid and there's a thin layer is coming in front of their vision. So this is the cause that where the aqueous humor plays a very major role, and the pressure of that intraocular is playing a very major role here. This leads to atrophy of retina, also leading to the blindness also. Like when the cataract become mature, that becomes mature. So that time that is called as a black motia. So this is the condition. If that is not treated properly, so it goes in the blindness condition also. So what are the function? It helps to maintain intraocular pressure and thus maintains the shape of eyeball. It is rich in ascorbic acid, glucose and amino acids, and then nourishes the cornea and lens. And what is vitreous humor? It is vitreous humor, or the vitreous body, is a colorless, transparent jelly-like substance which fills the posterior segment. Like you can see in this, this is in a posterior segment, and the eye and behind the lens. Because the aqueous was anteriorly, it was in front of the lens, and this vitreous is in the backside, in the posterior part of that particular lens. And it is enclosed in the delicate hyaloid membrane also. It helps to preserve the spherical shape of the eyeball and support to the retina. The lens of the eyeball is a crystalline in nature. It is situated behind the pupil. It is biconvex, transparent, and elastic in structure. The lens reflects light rays and helps to focus the image of the object on retina. Lens is supported by suspensory ligament, which are attached with the ciliary bodies. What are the accessory organs of the eyes? We know about that: eyebrows, eyelids and eyelashes, lacrimal apparatus, and conjunctiva. After that, we are reaching toward that which muscles are going to hold that particular eye. That is also a very important. When we were learning from sir, from the cranial neuromanual therapy, where sir has explained in a very easy way that how we can see, we can understand about the extraocular muscles. That is very important, plays a very important role. These are the muscles, that is the levator palpebrae, superior oblique, inferior oblique, superior rectus, medial rectus, lateral rectus, and the inferior rectus. As sir was showing on that their skull model, with where sir has attached that, made that muscles, the lateral rectus, medial rectus. So it is very important, plays a very major role when we going to treat the patient with the myofascial dysfunction. That time we treat these muscles. Because of that, we sometimes we have to give myofascial release, or we have to give muscle energy technique, or in a neurodynamic positioning itself we can give and we can release that muscles also. Because sometimes there is a tightness, sometimes there is a trigger point in superior and the inferior orbital. So there are the way we can treat the patient. So we know that the movement and position of extraocular muscles, that is also very important to know that these muscles plays a very major role in elevation, depression, medial, lateral, as the external rotation. Like we can easily apply on our eyes also, that we can see, we can elevate our eyes, we can depress our eyes, we can take internal rotation. Like we are going to see towards our nose. So it means we are going to see in the internal rotation, or we can go see to outside the vision. So there is an external rotation, or we can check that abduction and adduction. Like when we are focusing on our nose, this is the adduction. And when we are taking the eyeball towards the opposite side, it is the abduction of the eyeball. So it is also very important. Same like the in a myofascial part, we check the adduction, abduction, extension, and flexion. So that is the same as the elevation and depression. If we are talking about the elevation of eyeball, so it means the superior movement is coming. If I am talking about the depression, it means the inferior movement is coming. If I am seeing towards the inside the towards the nose, it is the internal rotation. Or if I am going to see towards the outside, it is the external rotation, like abduction, adduction, and medial and lateral. So these are the same phenomena which we, as a in all the muscles we see the same. The extraocular muscle plays an important role for the eyes. If the in the particular in one direction the muscle is tight or not able to give the movement to the eyeball, it means there is a tightness in a one muscle. And the synergistic muscle, or the we can see that there is a muscles which plays a very important role with the as a synergistic muscle. So we can check both that muscles also for releasing the myofascial release. The superior rectus, I have already explained that elevation, adduction, and intorsion movement. Where the intorsion is coming, that is how we check with the intorsion movement. And inferior rectus, the depression means we are seeing towards the downward. Adduction, we are seeing towards the nose. And extorsion, we are seeing towards the outside. So this is also sir has explained in that course very beautifully. And the medial rectus, what is the function of medial rectus? Is the adduction, and the lateral rectus is the abduction. So it means we can easily say, if the medial rectus is not in a proper functional, So it means there is a paralysis where the patient is not able to adduct their eye. So if there is a lateral rectus paralysis, so it will not be able to abduct their eyes. And the superior oblique, the depression, abduction and intorsion, and the inferior oblique, elevation, abduction and extorsion. It is very difficult to remember all these things. It can be possible if we do on ourselves that eye movement, then we can easily remember. Otherwise, it is very difficult. What is intorsion, and the extorsion and adduction, abduction of eye. And there is a conjugate movement when the both eyes moves in exactly the same direction with the visual axis being a parallel, and deconjugate movements when the axis of both eyes converge and diverge. And there are a clinical significance also for these muscles. The paralysis of these muscles are the strabismus or the squint. This is the unilateral paralysis of individual muscles as a result of engagement of nerve create a strabismus or squint, means the double vision deviation of the eye to the opposite side. We have seen some patient where we have seen the diplopia, the double vision, where we have seen that the division of the eye to the opposite side. So these are the things which clinically related to these muscles when they are paralyzed and they are not in a working position. That time the patient feel the weakness in particular that muscle, like if the lateral rectus, the abducent medial squint comes, and the medial rectus, so the oculomotor lateral squint comes, because these muscles are related to particular these cranial nerve. Because if I am talking about the lateral rectus, it means that abducent nerve is not in a proper function. Or if I will talk about the medial rectus, so oculomotor will not going in a proper working. So there is a medial and the lateral squint is coming. So we know that medial rectus, it is a muscle in the orbit. As with the most of the muscle of the orbit, it is innervated by the inferior division of the oculomotor. It means if there is a cranial nerve is pulse is coming, or there is a cranial nerve problem, so the patient is having a problem with the medial rectus. So the patient will not able to adduct their eyeball movement in the adduction side will not be possible. So these are the things which we have to, when the sir will explain as a practical demonstration, that time we can easily understand that what is the role of oculomotor nerve for the medial rectus muscle. And we know that the function of medial rectus, the eye movement, where the contraction of the medial rectus pulls the eye towards the nose, because the adduction, so it will pulls towards the nose, and the adduction or medial movement of the eye. Contraction of lateral rectus pulls the eye away from the nose, that is the abduction or the lateral movement. And the medial rectus is an adductor and work along the lateral rectus. They both work together, because we know that we are not placing our eyeball in a one position. Sometimes we have to see, if we want to see opposite side, so how that lateral rectus will work. If we want to see in the same direction, how the medial rectus will play the movement. So these muscles allow the eye movement from side to side. The medial rectus is innervated by inferior division of cranial nerve 3, that is the oculomotor nerve. In this, you can see that poor eye control. In picture, the baby you can see. So in this, there is a strabismus condition where the two eyes are misaligned, and therefore the point is different in the direction. So the direction of eye is not in the same proper, not the eyeball is going in a side by side, because of that poor eye control of the medial rectus. In this also you can see that deviated eyes, the right medial rectus paralysis, extropia in a primary position, and overreaction of left lateral rectus muscle, exotropia. This is lateral rectus, that is also you can see. Sir, I need 2-minute break, sir.
Yes, Ritma.
Yes. After this medial rectus and the lateral rectus, now we are going towards the nerve supply of the eyes. That is also a very important part, as you can easily see in this that how the nerves, according to that, if I will talk about the osteo part of the skull, so that all the branches of that nerves which are coming from the frontal nerve and the oculomotor nerve, supraorbital nerve, supratrochlear nerve. So these are the nerve that the lacrimal nerve, in infratrochlear nerve, short ciliary nerve, ciliary ganglion, they all are attached to the articular part of the skull also. So it means they are, if there is a some pressure problem or if there is a nerve dysfunction is coming, so it will affect the osteo part of that particular area also. All like the sutures also will go in the dysfunction sometimes because of that nerves are in an entrapment. So it will create the, like in our OMPT, we learn according to the articular, myofascial and the neural part. So it means that if there is a dysfunction in a particular cranial nerve, it will affect the myofascial part, the muscular part of that orbit muscle, that is extraocular muscle. And if that muscles are in a tightness or they are in a spasm, it will affect the working of that particular articular part also. So it is now very clear that why the physiotherapist should understand the movement of that particular eye or the dysfunction of the visual problem, because there is also a very major role of articular, myofascial and neural. So we cannot forget that these are the eyes are the part of our body, our skull. So how we can as a physiotherapist not treat that area, because as a in our MPT we learned the neuromanual therapy, or we learned the osteocranial neuromanual therapy, or we learned the osteomanual therapy. It means the role of these visual dysfunction or disorder gives a scope of a physiotherapist that they can treat their patient visual problem also by treating the combined structure of articular, myofascial and neural also. And yes, we can proudly say that we are learning about the vascular system also. What are the veins, what are the arteries which are going to supply, and where is the venous drainage is coming. Or as we know that there is a vascular part in the inner layer of the middle layer of the eye is made up of the vascular part. So it means there is a vascular insufficiency also, or we have to treat the vascular part also. So this is all very important. So don't think that this topic is only for the optometric and the students of that ophthalmology. No, this is also a very mandatory part for the physiotherapist also, because there are the nerves, the cranial nerves, which are going to supply, either they are sensory, either they are motor. So if they are not in a proper functioning, they will create some dysfunction in patients myofascial and articular also. So there is a blood supply, which ocular blood supply, that is the carotid artery, which supply the ophthalmic artery. And according to that, this ophthalmic artery divide into posterior ciliary arteries and the retinal, where the internal part, the retina, there is a retinal artery, and the muscular arteries, which supply the extraocular muscles. And further, these muscular arteries supply the anterior ciliary arteries, and which is going towards the iris also. And if I will say about the posterior ciliary artery, there is an anterior optic nerve choroid artery also. So, and this is after the anatomy. Now we are going towards the nerves passing through the superior orbital fissure. According to that, we will plan our treatment by the understanding of that, either the cranial, which cranial nerve is going in the dysfunction. According to that, with the nerve with going to affect the which muscle, either the lateral, medial or superior, inferior, oblique muscles, or which are the articular part, either there is a zygomatic bone or there is a frontal bone, they are going, or there is the occipital region from where these nerves are attached, the optic nerve pathway itself also, how it is affecting the way. So after that, we will learn about the treatment plan and how we, as in a AMPT, we start our evaluation and we do give the treatment with the cranial neuromanual therapy. We can treat the cranial nerve. So after the anatomy, this part is going to give you a very different view how we can treat the cranial nerve also. Yes, sir.